Antiviral Properties of Sunlight, Part 2. This is the second part of a multi-part discussion on this topic. Today we will discuss how sunlight indirectly produces two powerful immune hormones, melatonin and calcitriol. Before discussing the physiological actions and therapeutic uses of these hormones, I would like to briefly provide some background on the nomenclature and origin of the discovery of these hormones. Melatonin's name is derived from a combination of Greek words meaning black or dark, and the chemical name serotonin. Melatonin was coined by Aaron Lerner in 1958. The terms melanin, which is the pigmentation in vertebrate animals, hair, skin, melanin and melatonin are chemically related, although they serve very different functions in the body. Both compounds are derived from amino acids and are involved in skin pigmentation regulation, with melatonin often inhibiting the synthesis of melanin. Origin. Both are derivatives of amino acids. Melanin is derived from tyrosine, an amino acid, and melatonin is derived from tryptophan, another amino acid. Function. Melanin is a pigment responsible for skin, hair, and eye color. Melatonin is a hormone that regulates the sleep-wake cycle. And in this YouTube, we're going to be emphasizing a different role, or a different hormonal role for melatonin, that of an upstream driver of antioxidant pathways. And by doing this, it has very potent antiviral properties. The other immune hormone which we will discuss is calcitriol, which is derived from vitamin D3. The origin of the term. Calci refers to calciferol, which is another term used to describe vitamin D3, which is synthesized in the human skin in response to ultraviolet light. Triol, in the name calcitriol, refers to the triol chemical structure. These are alcohol groups, OH groups, oxygen and hydrogen. These are also known as hydroxyl groups. So triol means there are three alcohol groups, three hydroxyl groups on this molecule, calcitriol, which is the most powerful immune hormone in the body. These alcohol groups, which give it the name triol, are at the 1, 3, and 25 carbon positions. The chemical structure of calcitriol is shown on the lower left of this slide. I would now like to provide a short narrative to describe how calcitriol is formed, starting with the solar spectrum. The visible spectrum spans from red to violet. Shorter wavelengths are known as the ultraviolet. And when ultraviolet sun rays hits human skin, they interact with a cholesterol metabolite, 7-dehydrocholesterol. This ultraviolet photon is very powerful. It breaks a specific bond in this cholesterol metabolite. As it breaks the bond, the resulting molecule changes form and becomes vitamin D3, calciferol. At this point, we can refer to calciferol as the skin vitamin D metabolite. It is not active at this point. It cannot bind to a vitamin D receptor, also known as a VDR. And vitamin D receptors, shown just above the chemical structure of calcitriol, are the transducers of hormonal signals, such as provided by the hormone calcitriol. If you look at the structure of the vitamin D receptor, you'll see a green element. That's the size of the calcitriol molecule binding to a pocket inside the vitamin D receptor. Once the vitamin D receptor becomes activated by calcitriol, it can migrate to the nucleus, interact with the DNA, and activate vitamin D responsive gene elements. There are 2,000 of these genes in the human genome, which contains 20,000 genes. So activated vitamin D receptors can directly modulate 10% of the human genome. This is why calcitriol is the most powerful immune hormone in the body. That does not negate the importance of melatonin as an immune boosting hormone. In contrast to calcitriol, which is derived from the interactions of the body with ultraviolet light, melatonin is derived from interactions with infrared light. Infrared light can penetrate many, many centimeters into the body, reaching mitochondria in virtually every organ of the body. And it is here that melatonin is synthesized. Now, many people are familiar with circulating melatonin, which comes from the pineal gland. That's only about 5% of the melatonin that's produced in the body. 95% of melatonin is produced within mitochondria, and that is stimulated by infrared lights, infrared photons. Now, in terms of actions, back to calcitriol. Calcitriol is the active form of vitamin D3. It is hydroxylated, and its full name is 1,25-dihydroxyvitamin D3, indicating that the vitamin D3 backbone molecule has 2 additional hydroxyl groups on it at the 1 and 25 carbon positions. So calcitriol plays a critical role in calcium and phosphorus homeostasis in the body. It is primarily used as a medication to treat calcium deficiencies, bone diseases, and hyperparathyroidism in patients with chronic kidney disease or parathyroid issues. Key uses and functions: kidney disease and dialysis. Calcitriol is essential for patients with kidney disease because they cannot adequately convert calcifediol, which is 25 vitamin D3, into 125 vitamin D3. That's because damage to proximal tubules in most cases. Because of this deficiency in the conversion of vitamin D metabolites into calcitriol, it leads to low calcium and high phosphorus levels in the blood. And these are deleterious because these can cause damage to blood vessels. So calcitriol and an analog of calcitriol, a synthetic analog, paracalcitol, are used by kidney doctors, nephrologists, to supplement the missing calcitriol. Calcitriol is also used to treat bone health. It promotes the absorption of calcium from the intestines into the bloodstream, which helps in maintaining bone density and treating conditions like osteoporosis. Sidebar comment: over 10 years ago, endocrinologists in China found that very low dose calcitriol, 0.25 micrograms per day, reversed postmenopausal osteoporosis in women. Immunomodulation, and this is what this YouTube is focused on. Calcitriol, by stimulating vitamin D receptors, has potent ways to modulate the immune system, including boosting antioxidant pathways, which participate in the functioning of the immune system. Research indicates that calcitriol plays a role in both innate and adaptive immunity, with potential applications in reducing inflammatory conditions. And that's what I've emphasized with this remark: boosts antioxidant pathways. Here is a link to part 1 of this YouTube series. We ended part 1 with a discussion of the life of the famous Norwegian composer Edvard Grieg, who had severe tuberculosis, which he contracted when he was 17. His left lung collapsed as a consequence of this tuberculosis infection, and he was left with pleurisy, which is an inflammation of the lining of the lung cavity. There are two membranes that slide on each other and they become inflamed. This causes sharp, intense pain. So Grieg, living in Norway, was aware that Norwegian winters were a threat to his health. Frequently, he would take a steamer from Norway to Italy to spend the winters, seeking the warmth and the sunlight of that Mediterranean country. By being exposed to frequent sunlight in Italian winters, Grieg was able to boost two key anti-inflammatory hormones, calcitriol and melatonin, and this improved the status of his lungs as well as other aspects of his physiology. So in the late 1800s as well as the early 1900s, before the advent of antibiotics, the use of artificial lights to mimic sunlight were used to treat people with tuberculosis. And this picture from Finland in 1934 shows children with tuberculosis obtaining phototherapy treatment. So the lamps include a broad spectrum sun lamp as well as an ultraviolet light. So instead of relying on the body to produce calcitriol from vitamin D being made in the skin, in older people that can be impaired because of a variety of reasons, including kidney injury. And for that reason, the use of calcitriol to treat tuberculosis is being used currently in clinical trials on people. And I'd like to point out a couple of important references. This one from 2022. The immune hormone calcitriol, its supplementation accelerates the recovery of patients with tuberculosis who have vitamin D deficiency, a randomized single-blind controlled clinical trial. Now, sidebar comment, when physicians and scientists refer to a vitamin D deficiency, they are referring to the liver metabolite, 25-hydroxyvitamin D3, calcifediol. They're not measuring vitamin D3 in the serum. So the liver metabolite is what's commonly used by health professionals to judge immune status. And we have discussed on this channel the benefits of boosting serum calcifediol levels from 20 to 30 nanograms per mil in that range to much higher levels, between 50 and 80 nanograms per mil. The normal reference range, according to Mayo, is 30 to 100 nanograms per mil. So boosting calcifediol levels is one strategy that integrative medicine physicians frequently use to treat patients with chronic illnesses, including IAC conditions, infection-associated chronic conditions. Here is a paper where calcitriol is not being delivered orally, but through inhalation. These are micron-sized particles. They're prepared for inhalation. Preparation and evaluation of low-dose calcitriol dry powder inhalation as host-directed adjunct therapy for tuberculosis. What that means, host-directed adjunct therapy, that's an add-on to existing therapies, such as the use of lights or antibiotics. Host-directed means you're boosting the health of the body's tissues rather than going after physiological processes inside the pathogen itself, such as what is usually occurring with antibiotics. So it's not an either-or situation where you're using either pathogen-directed therapeutics, antibiotics, or lamps and inhaled calcitriol to boost innate immunity. What they're saying is adjunct therapy is an and condition. use these approaches, including low-dose calcitriol powder, to inhale it, use that in combination with antibiotics. And that's a theme that we will emphasize throughout this YouTube series, adjunctive therapies. Now a couple of photographs from the photographic history of light therapies, photos from 1900 to 1950. This first photograph shows a child wearing goggles and held by a nurse while the child undergoes sun ray treatment at Cheney Hospital for Children, Chelsea, United Kingdom, in 1928. This full spectrum light will stimulate the formation of both calcitriol and melatonin. The light stimulates the formation of vitamin D3 in the skin. That metabolite is then brought to the liver, where it's hydroxylated, becomes 25 vitamin D3, then is taken to the kidney, becomes 125 vitamin D3. Both the liver metabolite and the kidney metabolite are active immune hormones, and they're also anti-inflammatory antioxidant hormones. Melatonin being stimulated by infrared light, which is likely being generated by this broad spectrum lamp, is also an antioxidant hormone. In addition to suppressing susceptibility to tuberculosis, it also means of reducing susceptibility to many microbial infections, including viral respiratory infections. Here's a woman being treated for skin complaints in 1932 using infrared light therapy. In this case, calcitriol is not being stimulated because vitamin D is not being made through the action of the infrared photons. Instead, those infrared photons are stimulating the production of melatonin. And this is similar in concept to modern red light, near-infrared light boxes, which are increasingly used by many populations throughout the world. In fact, near-infrared and red light therapies are being considered by space agencies to treat astronauts in microgravity. Here's a new paper, Near-Infrared Red Light Therapy, a Potential Countermeasure for Mitochondrial Dysfunction in Spaceflight-Associated Neuroocular Syndrome. Spaceflight-Associated Neuroocular Syndrome, SANS, formerly known as Visual Impairment and Intracranial Pressure Syndrome, is a condition occurring in astronauts during long-duration spaceflight. It causes structural eye changes, including optic disc edema, retinal folds, and hyperoptic shifts. It is likely caused by cephalid, that means moving towards the head, cephalid fluid shifts, and increasing intracranial pressure in microgravity. So, boosting melatonin is one way that the reactive oxygen species, the oxidative stress associated with this SANS condition, can be potentially reduced in ocular tissues. I would like to recommend this recent review. Melatonin, both a messenger of darkness and a participant in the cellular actions of non-visible solar radiation of near-infrared light, abbreviated NIR. Sidebar comment: the analysis of the impact of near-infrared light on the production of cellular melatonin is complicated. That is because much of the melatonin that is produced by mitochondria stays within cells. Some of it may be secreted into the serum and may appear also in the urine. However, the majority of this melatonin is acting intracellularly, and so for physicians interested in analyzing the effects of near-infrared light on cellular physiology, it is likely best to look at the cellular component of blood draws. In doing so, one can differentiate between the amount of melatonin in the serum versus the amount of melatonin within inside cells. Now shifting the narrative back to the upstream drivers, the initiators of ferroptosis. The upstream drivers of ferroptosis are frequently reactive oxygen species, abbreviated ROS, R-O-S. Some background on the discovery and impact of the concept of ferroptosis. The phenomenon of ferroptosis was discovered in 2012. Since that time, the number of papers on ferroptosis has begun to surge, particularly during the COVID pandemic. As of 2026, there are approximately 25,000 papers that have been published so far on ferroptosis. That is because it is now recognized that ferroptosis is a key pathophysiological mechanism underlying a wide spectrum of disorders, neurological disorders, heart disease, vascular disease, renal disease. So the focus in medicine is going to change, and when a condition is diagnosed, one of the first key questions that a health practitioner and a patient should be thinking is, how does one attenuate the ferroptosis associated with this condition? Ferroptosis is a form of iron-dependent, non-apoptotic programmed cell death, characterized by the lethal accumulation of lipid peroxides, distinct from apoptosis or necrosis. These are other forms of cell death. Ferroptosis is triggered by the failure of glutathione-dependent antioxidant defenses, specifically GPX4, glutathione peroxidase 4, and it is associated with iron-dependent lipid peroxidation. Ferroptosis plays a role in cancers, neurodegenerative diseases, and ischemia-reperfusion injuries. Ischemia is lack of blood flow, which produces hypoxia and/or anoxia. When blood flow is returned to an ischemic tissue, this is called reperfusion. And reperfusion of tissues that have been ischemic leads to ischemic or ischemia-reperfusion injuries. A major cause of ischemia-reperfusion injuries are reactive oxygen species, ROS, which are key drivers of ferroptosis. The reactive oxygen species are being produced as a consequence of oxygen being rapidly delivered to the ischemic tissue. The mitochondria, and more specifically the antioxidant enzymes, are not prepared for the rapid production of reactive oxygen species, and this sets up the stage for lipid peroxidation, which will ultimately drive forward the process of ferroptosis. So many researchers and health practitioners are concerned with how to reduce the impact of ischemia-reperfusion injuries, and boosting melatonin to stimulate the production of antioxidant pathways, some mediated by the anti-ferroptosis, anti-inflammatory antioxidant transcription factor, NRF2. Now shifting the narrative to bacterial infections. We discussed tuberculosis earlier in this YouTube, how it impacted the famous Norwegian composer Edvard Grieg. So the damage to lung tissue during tuberculosis, it has now been found that ferroptosis plays a major role in this. So I would like to read the abstract from this paper. A major role for ferroptosis in Mycobacterium tuberculosis. Mycobacterium tuberculosis is the species name for a specific type of bacteria that commonly produces tuberculosis. So they're discussing ferroptosis in Mycobacterium tuberculosis-induced cell death and tissue necrosis. These are the pathophysiological processes that are producing the symptoms characteristic of tuberculosis. Necrotic cell death during Mycobacterium tuberculosis infection is considered host detrimental since it facilitates mycobacterial spread. So in other words, the cell death is facilitating the spread of the mycobacterium. Ferroptosis is a type of regulated necrosis induced by accumulation of free iron and toxic lipid peroxides, peroxidated lipids. We observed that Mycobacterium tuberculosis-induced macrophage necrosis, this is the necrosis, the cell death of infected macrophages, is associated with reduced levels of glutathione and glutathione peroxidase 4, GPX4, along with increased free iron, mitochondrial superoxide, and lipid peroxidation, all of which are important hallmarks of ferroptosis. Moreover, necrotic cell death in Mycobacterium tuberculosis-infected macrophage cultures was suppressed by ferrostatin 1, also known as FER1, a well-characterized ferroptosis inhibitor, as well as by iron chelation. Sidebar comment. One of the upstream drivers of ferroptosis is the accumulation of ferrous ion. That's Fe, which stands for iron, 2+. It's a cation, positively charged ion with 2 positive charges. Excessive amounts of free iron in cells will set off reactive oxygen species chemistry that leads to lipid peroxidation, which drives ferroptosis, this programmed cell death. Additional experiments in vivo revealed that pulmonary necrosis in acutely infected mice is associated with reduced GPX4, glutathione peroxidase 4 expression, as well as increased lipid peroxidation, and is likewise suppressed by ferrostatin 1 treatment. Importantly, ferrostatin 1 treated infected animals also exhibited marked reductions in bacterial load. Together, these findings implicate ferroptosis as a major mechanism of necrosis in Mycobacterium tuberculosis infection and as a target for host-directed therapy of tuberculosis. Now, this last phrase, host-directed therapy of tuberculosis, what they're meaning is that in contrast to antibiotics were directed at the pathogen, the bacterium, here the therapies are aimed at the host tissues, namely to suppress ferroptosis, which is leading to cell death and the release of mycobacterium from inside cells, particularly macrophages. These are known as big eaters, macrophage, big eater. They become infected by the bacterium. How do they do that? They try to eat the bacterium, but the bacterium evades digestion and begins living inside the macrophage in a structure known as a phagosome. And here the mycobacterium can proliferate, waiting for its chance to cause cell death. And now we know by the process of ferroptosis, releasing more mycobacterium to neighboring cells. And that is being described in this paper as a major means of propagating the tuberculosis infection. So what they're finding is by suppressing the process of ferroptosis, they can reduce the loads of bacterium in cells in the animal model of this process. What is ferrostatin 1? Ferrostatin, FER1, is a potent small molecule inhibitor of ferroptosis. acting as a radical trapping antioxidant to prevent iron-dependent peroxidation. It is widely used in biomedical research to protect cells from death in models of neurodegeneration, kidney injury, and ischemia-reperfusion, often showing efficacy at concentrations of 1 to 10 micromolar. And sidebar comment, small molecule is a term to contrast molecules that are under a few thousand molecular weight. They are generally more permeable, soluble, and in terms of pharmacology, they are often easier to deliver to tissues than a, quote, biologic, like an antibody. And so this compound is currently being widely used to inhibit the process of ferroptosis in a number of inflammatory, infectious disease, and autoimmune conditions. Why isn't it currently being used in humans? There is probably some type of side effect or toxicity preventing that. However, drug companies are rapidly developing other types of ferroptosis inhibitors, and those are more likely to be translated into human trials in the near future. Now, moving to the discussion of this paper. Interestingly, a number of other antioxidants possess ferroptosis inhibitory properties, including vitamin E, a dietary supplement that has been shown in several studies to improve tuberculosis treatment outcome when administered adjunctively, that means in combination, with conventional antibiotic therapy. Sidebar comment, earlier in this YouTube, we discussed a different vitamin D derivative derived from vitamin D, calcitriol, the kidney metabolite of vitamin D, 1,25-dihydroxy vitamin D3. By preparing a powder and inhaling that is currently being trialed and in humans and successfully. In addition, oral calcitriol is able to suppress tuberculosis in humans as well. So again, whether it's vitamin E or vitamin D derivatives, these are host-directed adjunctive therapies that can be used in combination with conventional antibiotic therapies. These observations raise the question of whether ferristatin 1 or its newer derivatives may possess similar or more potent activity against human tuberculosis than vitamin E, and conversely, whether vitamin E could be used as a ferroptosis inhibitor should the former drugs prove unacceptable for clinical use in this setting. As an alternative strategy, ferroptosis can also be suppressed by augmenting GPX4 expression and/or activity. Sidebar comment, one straightforward way to do that is to provide near-infrared light to stimulate the production of melatonin in mitochondria. Melatonin rising within cells will stimulate NRF2, the master anti-inflammatory antioxidant transcription factor. NRF2 in turn upregulates GPX4, which is an inhibitor of ferroptosis. So exactly what the authors are arguing, that augmenting GPX4 expression is a clinical strategic goal to suppress ferroptosis. So near-infrared light, sunlight, boosting melatonin are ways to potentially achieve that. This effect can be achieved through the administration of the trace element selenium, and that's because GPX4 is a selenoprotein. It contains selenium and needs that rare metal in order to function. So administration of the trace element selenium, which, interestingly, has been shown to adjunctively enhance the outcome of conventional tuberculosis therapy when administered as a nutritional supplement. Overall, this discussion emphasizes the critical need to boost host defenses and the health of host tissues. And in this case, a rare metal, selenium, is being supplemented because you need it as a cofactor in order for an enzyme, GPX4, to operate. And once again, GPX4 stands for glutathione peroxidase 4. It uses glutathione to reduce reactive oxygen species as well as peroxidated lipids. These are the key drivers of ferroptosis. I'd like to illustrate these points with a couple of references. This paper, Insight into the Mechanism of Ferroptosis Inhibition by Ferristatin 1. And this paper is published in 2020. Peroxidated lipids are products of oxidative degradation, where free radicals or enzymes attack unsaturated fatty acids in cell membranes, forming lipid hydroperoxides. These are peroxidated lipids. This chain reaction reduces membrane fluidity and functionality, causing severe cellular damage, triggering ferroptosis, a type of regulated cell death, and contributing to various neurodegenerative and chronic diseases. And this sentence in particular is important. In summary, glutathione peroxidase 4 and ferristatin 1, in the presence of ferrous ion, Fe2, produces, by distinct mechanism, the most relevant anti-ferroptotic effect, i.e., the disappearance of initiating lipid hydroperoxides. In other words, the damaged lipids that have been peroxidated, to reduce them and deplete them. GPX4 and ferristatin 1 can do this, and ferristatin 1 achieves this by depleting the amount of ferrous ion, Fe2. So if you probe for connections between melatonin and ferroptosis on PubMed, you'll find 129 results. Virtually all of these papers have been published during the COVID pandemic era. So this is relatively new information. It wasn't typically taught in medical school, and yet the understanding that ferroptosis underlies so many pathophysiological processes in many organ systems, this connection between melatonin as an inhibitor of ferroptosis brings together a new set of therapeutics. Sun, red light, near-infrared light, to produce melatonin as a means of suppressing ferroptosis. And once again, these recent papers indicate that a primary way that ferroptosis is suppressed by melatonin is by boosting NRF2, NRF2, which in turn upregulates glutathione peroxidase 4, which acts to reduce reactive oxygen species and peroxidated lipids, the key drivers of ferroptosis. If you search on PubMed for connections between long COVID and ferroptosis, there are currently 21 papers. This is likely to grow very rapidly. In addition, connections between melatonin and long COVID are likely to find that melatonin, by suppressing ferroptosis, helps alleviate some of the pathophysiologies of long COVID. In that regard, we need to look at red and near-infrared light boxes as a new potent way of stimulating melatonin as an anti-ferroptotic process. And here's a recent review published in 2024, Therapeutic Effects of Melatonin in the Regulation of Ferroptosis, a review of current evidence. Finally, here is a summary of the key concepts presented in this YouTube, which is the second part of a multi-part discussion on these topics. We have discussed two newly recognized antiferroptotic agents that are already used clinically in different contexts. So it is relatively straightforward to repurpose them or reconceptualize them as potent antiferroptotic agents that can be used in a variety of conditions. First is melatonin. By stimulating the upregulation of NRF2, melatonin is able to boost the levels of a key antioxidant enzyme, glutathione peroxidase 4, GPX4. This enzyme utilizes glutathione to reduce reactive oxygen species as well as peroxidated lipids, and in doing so is able to suppress ferroptosis. How is it possible to boost melatonin? In this context, not through oral supplementation. Instead, using sunlight or near-infrared light from commercial light boxes. In this way, melatonin can be boosted within mitochondria, deep within the body. The therapeutic goal in both of these therapeutics, melatonin and calcitriol, is to boost NRF2. And that key concept should be a key continuing medical education concept, a CME concept, that this transcription factor, getting health practitioners to think about epigenetics, and that by utilizing these therapeutics, one can boost a master anti-inflammatory, antioxidant, antimicrobial transcription factor. And it stimulates a variety of pathways. But in this context, we have talked about boosting the antioxidant capacity of cells. So the second therapeutic is the kidney metabolite of vitamin D, 1,25-dihydroxyvitamin D3, calcitriol. It too upregulates through the vitamin D receptor the upregulation of NRF2, which in turn upregulates GPX4, and by doing so increases the antioxidant capacity of cells, and by doing that suppresses ferroptosis. A better agent to use than calcitriol is paracalcitol, 1,25 vitamin D2. Paracalcitol is less calcemic than calcitriol. What is calcemic? Calcemic is an agent that causes the concentration of calcium to rise within the serum. And this is an unwanted side effect that occurs when calcitriol is supplemented to patients. So over the last 30 years, a synthetic analog of calcitriol has been implemented, paracalcitol, 1,25 vitamin D2. It is currently the standard of care for chronic kidney disease patients who need replacement therapy for the missing calcitriol that their weakened kidneys are less able to produce. Paracalcitol is now being used in a number of small studies for the treatment of inflammatory conditions, mainly in kidney patients. Also, it has antimicrobial activity. One paper has been published, the use of paracalcitol and calcifediol, the liver metabolite of vitamin D, for the treatment of HSV-1 infectious keratitis. It's a herpes simplex virus 1 infection of the cornea. The eye was successfully treated with standard of care acyclovir with paracalcitol and calcifediol as adjunctive therapies. And that again stresses a key takeaway concept of this YouTube series. We've been talking about boosting host factors as the therapeutic goal. This is different than antivirals that are directed at viral replication, like remdesivir or Paxlovid. The utility of utilizing host-directed therapies in combination with antimicrobial therapies is that the damaging effects of antivirals, antimicrobial agents can be potentially mitigated by utilizing these agents, which help boost the capacity of tissues to withstand the oxidative stresses of infections as well as the side effects of therapeutic agents. Finally, I would like to draw your attention to a series of YouTubes on the MedCram channel. These are lectures by Professor Roger Schwelt of the University of California at Riverside. Professor Schwelt is discussing the concept of light as medicine, specifically in the context of COVID, the case for sunlight in COVID. IR light, a randomized clinical trial, improves COVID outcomes. Infrared light reduces ICU stay. In addition, he has a YouTube describing his own use of California sunlight to treat hospitalized COVID patients in rapidly improving their pulmonary functions. Also, a YouTube on the treatment for long COVID, photobiomodulation for long COVID. On the right, you see a key concept. Mitochondrial efficiency improves dramatically under red light. I should say red light and near-infrared light. And so those concepts are embodied in the information vector A. By stimulating the upregulation production of melatonin in mitochondria, sunlight and near-infrared light have a host of benefits, one of which is boosting NRF2, NRF2, which in turn upregulates GPX4. And as we've heard in this YouTube, recently published papers indicate that boosting GPX4, particularly in the case of tuberculosis infection, is a way of suppressing the pathophysiological events of ferroptosis. In the case of TB, the bacteria, which are located within macrophages, are being released as a consequence of the ferroptosis. So by boosting GPX4, either by melatonin or by vitamin D receptor agonists such as paracalcitol, the treatment of infectious disease states like tuberculosis, lingering COVID-2 infections in long COVID patients, conditions that involve sustained periods of ferroptosis. These are known as IAC conditions, infection-associated chronic conditions. This is where sunlight, red, near-infrared light boxes, as well as vitamin D receptor agonists all fit into a therapeutic toolbox that health practitioners and patients can draw from. Finally, again, some key references, and I would like to again emphasize that this is relatively new material published within the last few years. Melatonin inhibits ferroptosis and delays age-related cataract by regulating SIRT6P, NRF2 GPX4, as well as another pathway. But I've underlined NRF2 and GPX4 to again emphasize that the benefit of melatonin here in inhibiting ferroptosis is in part mediated by the upregulation of NRF2 and GPX4. And also, once again, these two recent reviews. Therapeutic effects of melatonin in the regulation of ferroptosis, a review of current evidence. And melatonin and ferroptosis, mechanisms and therapeutic implications. If you would like a PDF slide summary of this particular YouTube, please visit the Google Docs folder highlighted in green at the bottom of the slide. Navigate to the subfolder Download First. Look for another folder on ferroptosis. Here you will find a PDF slide summary of this talk, which contains active links to other YouTubes on this channel as well as to pertinent literature on PubMed. This is the fastest way for you to navigate through my own YouTube channel. For instance, earlier this year, we posted several YouTubes on ferroptosis being driven by the gene silencing of GPX4, which is mediated by methylation of the gene's promoter, the GPX4 promoter. This is a semi-deep dive into the molecular genetics of gene silencing in the context of how viruses as well as injuries such as ischemic reperfusion injury can result in the depression of antioxidant capacity of tissues. When these enzymes like GPX4 are suppressed, ferroptosis is promoted. And so the issue of the treatment of ischemic reperfusion injuries is very pertinent to COVID and long COVID patients who suffer from numerous microclots, producing ischemia in different parts of their body. So these issues can be reviewed by watching parts 1, 2, and 3 of this YouTube series on this channel. With that, I will take a small pause and then we will proceed to part 3 of this YouTube series.